Yeah, that just 1 second. You got to give me a little bit of time. I welcome you all. This is a MedBix webcast. My name is Ramana Anamaraju. I'm the host. I'm not a no. I'm not Albert Einstein. I'm the maybe the present guest is close to Albert Einstein, female version of Albert Einstein. So welcome you all. So is a diversity is a my channel is healthcare media channel. It is a diversity. What we promote is diversity in thinking. Thinking and diversity is so important nowadays because it's not just a diversity in has to be including the organizational structures, mathematics and physics and arts and technology. All of them are important in the thinking to actually come up with a very good solutions. In order to get a good solutions, you need those. So my channel is that promoting that wide variety of thought process, wide variety of industry leaders from the healthcare. I wanted to interview them, and then I present a topic related to some kind of a history related to mathematics and physics, and then the accomplishment of the past and present, and connecting with the present. So it's going to be exciting. I have a very distinguished guest. Her name is Dr. Irene Dankwa. She's born in Ghana and grew up in, then she went to Barnard College. She is a nationally recognized healthcare leader. She worked in the NIH, National Institute of Health, and she worked for IBM Health. And she is now the presently chief equity officer for Meritive, formerly known as IBM Watson Health. And she was IBM deputy chief. Right now, she's IBM chief deputy health officer for the Meritive, the company, which is formerly IBM Watson Health. Well, let me bring her. Welcome. Let me bring Irene on the on the stage. Just to give me 1 second. I'm going to bring her. Irene, welcome. Welcome to MedBix webcast.
Thank you.
So
Thank
tell me your background. You came from, you were born in Ghana. Tell me, what is your experience of healthcare? How did you end up here? Is it the cross section of technology and medicine?
Yes, first of all, thank you for this opportunity to be here and have this conversation with you. I am very honored and I appreciate your reaching out and inviting me to your program. As you mentioned, I was born in Ghana, so that's where my roots are from. I was born there. I went to high school there and came here for college after I finished high school. I studied biochemistry at Barnard College and went on to also study medicine at Dartmouth College. I actually want to add that given my background, I was really interested in public health as well. I consider myself a public health professional, very passionate about population health. So I also got a master's in public health with a focus in infectious disease in epidemiology. And so I did both an MD and an M.P.H while I was in med school. So it was a 5-year program where I took my master's in public health at the Yale School of Public Health. Um, and so that's basically after I finished my medical degree in public health, I came to Baltimore and did my training in internal medicine. And after my training, I went and did, I came, so I was at Johns Hopkins Bayview, where I did my training, as I mentioned. And after internship and residency, I was recruited by the public health department in Montgomery County, where I worked for 8 years in public health, primary care, of course, health policy. So I had the opportunity to combine my training in internal medicine and primary care in public health. And it was a great experience working on frontline with communities, really promoting health and prevention, and ensuring that the populations that are marginalized or underserved or experiencing social disadvantage have the assets or the resources to help them thrive and improve their health. So I was there for 8 years. Yeah.
Since you are very good in technology and medicine together, I lived in Silicon Valley, and then I came back to Atlanta and back and forth. But I want to ask you, there is a buzz about artificial intelligence in Silicon Valley. Everybody talks about artificial intelligence. What role artificial intelligence can play or doesn't play in the equity, health equity that you are so passionate about in the healthcare arena?
Yeah, that's a great question. So I would say that there definitely is a role for these emerging technologies, which include artificial intelligence and machine learning as part of advanced analytics of data. There is a role because we have amassed or generated so much health data that we are unable to leverage to its full potential. The current data that we're using now to generate evidence, to inform clinical decision, to inform how to treat patients is mostly from clinical trials, which, as you already know, are very selective, right, of a few patients, or from, you know, um, data sets that may not be representative of the entire of the population or of different data sets, different populations. But we know that there's a lot of data. Your patient generated data may be different and unique to you than and mine as well. And so what artificial intelligence can do is able to look at all these data. I mean, we're talking about trillions of data that our own eyes or our own analytic capabilities is unable to analyze. We need sophisticated AI or emerging technologies, machine learning, to really to be able to help tease out, track disease patterns, identify, trends that occur in different patients, so that we'll be able to generate the scientific evidence that we need that's specific to different populations. Otherwise, we're just practicing one size fits all medicine. That's where AI comes in. But this is where we also really need to be very, very careful about how we're using AI. When I say careful, it means making sure that we're really looking at comprehensive data sets, right? Right now, AI may be used on just a limited few. If we expand it, that's where it can really help to address health equity because we'll be including the universe of data, the right amount of data to really develop insights.
So, Irene, the first challenge is the cleaning the data. There's a lot of flawed data there, right? This is not clean. A lot of bathroom data, people producing all kinds of data. That itself is artificial intelligence can fill up the gaps. You think in the future, like a clean up the data itself.
I think you make a good point that it's one thing to clean up the data, right? Artificial intelligence will definitely not help clean up the data. So we need to have the right data architecture, the right platforms, really to help promote AI. So you're making a right point. Absolutely true.
Okay. So another thing is I wanted to ask you a bias. Artificial intelligence is still is a program is created by the programmers like so many people. So if I am Indian, I create a more favor to Indians. You understand Indian culture. You're African, you understand. So the white, the Caucasian, they create. So this is a big problem. Is it? Do you think is a problem artificial, the bias in the artificial intelligence itself?
I think that we all need to be at the table to make sure that we're using artificial intelligence right. So it's not for the developers. The developers have to be open enough to work in teams. Everyone has a role to play where the clinical people or whoever will say this is the right content to use, or these are the right feature variables to use in your model. The developer, can put in all the statistical measures, but they need someone who would say this is the right feature variable based on evidence. This is what you need to, you're missing this data. So I think we all need to be at the table, right? And it's not just the developer who has to think abstract or go pull evidence that's available. They may not know what is out there. So it's really important that artificial intelligence become a multidisciplinary effort.
Absolutely, excellent point. So, you're saying that it has the artificial intelligence plays a significant role in creating by participation of diverse people, diversity in thinking itself, and the physicians and the life coach, all kinds of people should participate in this one. But there is, unfortunately, that is not happening in sometimes. In Silicon Valley, it is technology is defining what is the care systems are. So that itself can create a challenges, because the providers are confusing now. Is it technology is defining the care, or care is asking a help? The technology should supposed to serve the care providers than defining itself. Is it think that is a big? Do you think is a challenge in that area?
It is. That's a good question. I think we, for any technology at all, there has to be a human in the loop. So the technology is there to augment our decision making. It's not there to replace it or to serve as an assistant in comparative, what's the technology saying and what should I say? It's basically to add to the options or improve our decision making. I think that's one thing that needs to be clear. A lot of the time, people think artificial intelligence is there to tell us what to do. No,
Correct.
it's to give us options. So if you work on an AI model or algorithm, that model or algorithm needs to augment your. So usually, artificial intelligence is really augmented intelligence. To make us be better human beings, to make us be better, provide better clinical decisions. It should not be one or the other.
Irene, what do you see in the future that the access to healthcare, quality, social determinants? Give me some background on those areas. Why America is falling behind in healthcare system is like a headless chicken. It's a lost in space. In fact, what do you think? What we need to do to make this healthcare system better efficient? And what do you think of it?
I mean, I think, everywhere there, I mean, healthcare in itself is a complex space and field, right? Depends on the financing, it depends on the policies, right? It depends on the players in the healthcare ecosystem. So for every country, we are all trying to figure it out. Um, and in this era of COVID and pre COVID, I think a lot of healthcare systems are trying to figure out how to address the health disparities and inequities that are existent because COVID has basically exposed this. And so we have sort of a double whammy on us, with we're trying to figure out. I mean, right now, healthcare system is already broken, or it's really tough. Um, and we now have on our hands also to address inequities, because inequities really cost the system. Disparities within in every country is very costly. And I think what healthcare system needs to do is to prioritize prevention and primary care. A lot of the times we're basically chasing, after tertiary care or ill care, when if we put more money into primary care and prevention, I think that's where we will get good, better results.
Irene, I used to play as a J1 visa doctors, the doctors who are coming from other countries, they need underserved areas. I used to go there quite a bit to Selma, Alabama. I placed quite a few physicians there. When I went there, one of the things is I was shocked to know they don't have a, there is a, you see relatively overweight population much more than any other town. In Montgomery, you don't see that. But in Alabama, I asked the doctors there, what is the reason? They said that they don't have the nutrition for 10 years in the town. There is not even diabetes nutritionist is not available there for the town.
Mm.
So think about that, access to nutrition, access to a lot of these things. They education is important. That's a good start, at least whether they follow or not. Some people may follow and other people may teach other people. The young people, for example, are very health conscious and they teach their parents, how to be. So so this access to healthcare, how it is a big problem. Can we solve through the technology, you think?
No, I don't think we could solve it through technology alone. I think technology may be one of the ways to make healthcare delivery a little bit more efficient. But I think we could solve it by addressing, as you said, these social or determinants of health, which you gave an example as nutrition or food access. Um, we know very well from evidence that the social, environmental um, determinants of health are really important, and they account for a lot of the health, uh, and especially adverse health that we experience, or the disparities. Technology may be able to help identify, right, which particular factor, is prominent, if depend on the kind of technology. But I think really addressing and providing those resources, improving access, like you said, will do, will is very important and needs to be
So
prioritized.
I wanted to ask you about the companies, private companies. How can they install and deploy healthcare equity, understand their patients' problems? Even disease burden is different. Healthcare equity means it's not just a racial. It could be disease burden itself is a different, right? Some people with the diabetes. Explain that. Could you please explain that in a little bit more terms of disease burden area? Or generally people have a, it's not just a racial thing, it is all together. There's a poverty, the economic backgrounds is all involved, right, in the health equity.
Oh, absolutely. And I think that's a great point. So, in general, and definitions are really important, um, but also the underlying values and principles, especially when it comes to health and health equity, is even more important, right? And so the issue, health equity basically implies that everyone should have the opportunity to attain their full health potential. And no one should be disadvantaged from achieving this potential, right? And what's this potential, right? It's basically making sure that um, we help that, and that's why health equity is looking at those unfair differences, because it's a type of unfair difference that is associated or closely linked with your socioeconomic status, an environmental disadvantage, um, and it and so when we look at health disparities, it affects those groups of people who systematically experience greater obstacles to their health. And it could be based on race or ethnicity. It could be based on, um, you know, where they live. It could be socioeconomic status, being in poverty. It could be having a disability. Um, and so all these character or even other characteristics that are linked to discrimination or exclusion. So you're right. Health equity is more broad, not just race and ethnicity, but thinking about a particular type of health difference that we see in groups that are systematically experiencing greater obstacles to their health or from achieving that potential.
As you mentioned, Irene, health equity is a global problem. It's not just limited to the United States. What are the things that other countries is quick to adopt, or what is that we need to? What kind of things they have to do, including in the United States, to address the health equity? What they have to do actually?
Um, I think we right. I think one of the things to do is to look at health more broadly, right? That um, prevention, primary care, wellness. I mean, I think this is everybody's uh, priority. We all are participants in our health, but most important, we need to ensure that we are providing all populations or everyone with those resources. Some may need more resources or opportunities than others, but that's the goal and that's why health equity sort of is a process. But focusing on prevention. And when I say prevention, not just in the health sector, but also looking socially. In countries where where they have good social systems, social health, they do better on health outcomes. Um, we seem to in the United States, we're trying to connect, really expand on the social determinants of health, and the healthcare sector is now looking at transportation and food um, and all those social determinants that had been sort of in a separate category. I think when you look at that, that's where we need to go in terms of.
Irene, do you think the companies, like big companies, should hire health equity officers to really monitor that health equity itself? What is your view on that?
Yes, I mean, for the most part, I think you're right. After the COVID pandemic, there's been a rise of chief health equity officers, and a reason being that organizations realized the importance of health. Health is particularly important and essential to well-being, essentially essential to for someone to participate fully and contribute to society. And so ill health, having a disease or illness threatens an individual's ability to fully participate or be productive members of society. And organizations saw during the COVID how employees were vulnerable and how they needed to really, I mean, productivity was linked to, health and well-being. So you're right. Based on that, a lot of organizations are thinking about,
Well,
having someone, a chief health equity officer, who could look at not just the health of the employees, making sure there's diversity. These have all been proven to increase productivity in organizations, and foster innovation.
Irene, we talked about discrimination. I'm going to present a story. The discrimin really the effect of the discrimination of an extraordinary story of a human, the physician from India who came to United States. I'm going to present that. You're going to watch it with me, and then when I come back, I will ask you a question: what you're doing with the Meritive Health? What do you do? What they do exactly? You can give us some little bit background about your company, a little bit. Let me present this thing, and both we will watching together. Okay, so that let me. Okay, now I'm going to present about this thing, and okay, now I can see. He's a forgotten hero of medicine. Is hometown in is from my hometown. Actually, I'm going to explain to you. Nobody knows him. Nobody knows in the country he was born into. The nobody knows him in the adopted country, America, and the Nobel Prize Committee didn't know anything about. He did not. They did not recognize him. So it's a story of this man. I'm going to explain to you as a physician why is so important. I tell you what he is. He did a first chemotherapy drug. He discovered first chemotherapy drug, first broad spectrum antibiotic, first strip testing, first tropical drugs. Saved millions of lives. His drugs, his discoveries, still World Health Organization essential drug list. Still, his discoveries are listed there, but nobody knows him. He's a famously unknown man. Unfortunate, that is what the discrimination. I To talk about him a little bit, I need to talk about my hometown, where he is also from the same town. So I'm going to talk about a little bit of healthcare system in my hometown. I was born in a small village. Um, at that time, there was no electricity, no running water, no healthcare. My father was a doctor. He's a teacher, and there is no other doctors in the village. So he self-taught himself to be a doctor. Really, he's a great doctor in my view, and he inspired so many people to be doctors from there, and then they are working around the world right now. But anyway, that is a village. It's a very picturesque place, and there's a lot of coconut trees and a lot of rice paddies and rice fields. It's a very picturesque place. We are a tropical town. I'm like a village 10 miles away from the sea. But the as you know, the diseases are during that time is when is or typhus, malaria, cholera, bacterial, parasitic, all these the viral infections are very common infections. That is the all of them are usual suspects in the diseases. But in addition to that, in my hometown we have a cobra bites. A lot of people used to die with the cobra bites. You believe me or not? You see snake charmers all over my town, all over my village. In fact, so I used to watch snake charmers. So now I feel that I'm so close to. People are so close to that snake charmer. Could be. I used to watch it like that kid, close to the cobras. But cobra is very poisonous. It can kill you within 12 minutes. But that is a big problem. The other problem is some suicide. That there's not much, but I heard in my entire high school, one person is called he drank the endin. It's called endin, which is a pesticide. He drank and died. So very few, but there is no chronic diseases. There are probably there, but they're not prevalent. You don't see them. Um, Probably less also in my view, because even though you would have, we would have noticed it, the chronic diseases are, but it's not. I think it is a modern day problem. So, what is the healthcare in village? My father used to go in a bike, in a bag, and I used to go with him sometimes. You go to the rural village, they go and see the patients right there in their house, and then they treat them, all of them, and give them medications. It's a very small village area. All the doctors do the doctor's bag, and then they go there and do stethoscope. And my father used to do that. He was a teacher also. He was teaching the daytime and the evening time. He was doing this. But the pregnant woman, they go. Midwives are the most way of delivering babies. I was born through midwife, at home. So there's a lot of people are doing that. It is very common. Still, it is in a rural India, and I'm pretty sure that Irene can tell you, in Ghana, also in rural areas, they still midwives are prominently, they deliver babies. But so healthcare is kind of efficient in a way, because you're doing diagnosis, you're doing a treatment, you're doing prognosis same time in same visit. So the doctor is going, care is going to the home. Now we are talking about all these years. We want to take the delivery of care. We are reinventing. We are trying to find providing the care to the homes. You know, Amazon is trying. Everybody's trying. So this has already been there. In India and Ghana and other countries, the providing care they may not have all the tools, but the care system, delivery system, is very efficient if they have the tools. So it is existence that they go there and they see the patient, diagnose it, and give the medications and prognosis same time. They do all of them. But the basically, how do they get paid? Yeah, I don't know about Ghana. I'll ask her when I get back. But in India, they used to do, particularly the doctors of Hindu origin or Muslims, they used to do a religious function. People come, and is like American system in 1920s and 30s, give a doctors chicken and eggs. We are vegetarian, so they give vegetables and rice and all those things. They used to give it to us. So they do a vegetable. They pay cash sometimes. If you're rich patient, they pay cash, or sometimes gold, silver, all of those things they do. So that is a medicine of paying basically. That is the story of my father. My father is a doctor, and is a teacher, doctor extraordinary. He's a really sacrificed, and he did a lot of things to my village where the healthcare is non-existent. My mother probably put up with the brunt of that iniquities it herself. So at home, and he is spending a lot of more his own money to take care of the patients. But this story comes back to this man. His name is Dr. Yellaprakada Subbarao. Nobody knows his name is a long, is a complicated, lost, a lot of vowels and letters there. But you need to know about him. I tell you why you need to know. He was born in a same town. I'm from a village, but we are away from 3 miles away from the big city, big town. It's not a big town. It's a small town. It's a little bit better than village, and it's called Somarama. It is a Bhimavaram. It's called right now. It is the sacred temples of 5 Lord Shiva's temples is located one of the. That's why the name is Somarama. Bhimavaram came from that connotation. You know, so it is a sacred temples located. One of the 5 sacred temples of Lord Shiva is located in that town. Dr. Yellaprakada Subbarao was born there. He was born in 1895 and he died in 1948. He was born in 1895. Okay, so he married. He was a child marriage. He got married with the age of 15. So child marriages are very very common at those days. So he got married. He doesn't want to go to school. He failed. He doesn't want. He failed high school 3 times. This man failed high school 3 times, and then he wants to do in business. He wants to do some vegetable trading and all those things. But his father-in-law thought he's not going to take care of his daughter, so he wanted to send him to the medical school. He sent him to. He has some money. Father-in-law gave him money to go to medical school in Chennai, Madras. Now it's called Madras. Is now it's called Chennai. Is like 300 miles away from my hometown. So at that time, India is under the British rule. It is Queen Elizabeth is 15 years old. So we are under the British rule. He studied medicine. It's a traditional medicine. It's a anatomy, physiology, all those things. He did a basic courses in surgery and materia medica, all the pharmacology, all those things that you do in the traditional medicine. He did that during the time in beginning of early 1900s. Then he worked in the Ayurveda College, which is a plant-based medicines in the local India's traditional medicine. These are traditional medical system. He was teaching in one of the schools, prominent schools in Chennai. Became a teacher, but he was not trained in the Ayurveda. He was teaching traditional medicine, English medicine, allopathic medicine. He's teaching. Then he applied for Harvard Medical School in 1923. So they rejected him application because he said they thought he is a Ayurvedic doctor. They don't want him. So he sent his letter saying that he did the traditional medicine. He was just teaching in the Ayurveda school because that is the only place he can find a job. So I asked him to reconsider. So Harvard gave him admission in 1923. So he came down. I think he came by ship, or I'm not sure, he flew. Something, one of those things happened, but most likely ship, I thought. So he was admitted into the tropical medicine school. Then in 1923, it's one of the 100 years ago. Think about that, guys. So then he did a PhD in biochemistry, and then he did a medicine in the tropical medicine. Then they hired him as a tropical, they hired him as a faculty member in Harvard in 1930s, in the beginning of 1930s. But they did not provide him tenure. They denied all his inventions were stolen, or they did not publish it. He felt extremely saddened by that. All his friends are telling the Harvard is, this such a great institution. During that time, he felt a discrimination. It is written in the Wikipedia. I'm not making up. It is, when you read about him in the Wikipedia, it says he was clearly discriminated. They found his papers after his death. I will explain. So he left Harvard and then joined in the Letterly Labs. At that time it's a very small boutique lab. It's a lab. They're doing a lot of drug discoveries and all those things. So he was denied tenure. He was denied. He discriminated. He was discriminated. He has stolen papers, all of them. So he went to Letterly Labs. Yeah, during that time, he invented a first strip test for the phosphorus. As you know, the mineral in the body, first mineral is a I forgot, calcium, right? Yes, blanking out sometimes. Calcium is the first mineral. Higher the next mineral in the body is the phosphorus. So he created a phosphorus test, a blood test for the strip test. First strip test he created it in the during the tenure, during the time in Harvard and the Letterly Labs. So that is the first invention. The second invention, he invented a drug called hetrazone. Hetrazone is a drug. It is now part of the World Health Organization essential drug. It is now they're thinking it is probably extending as a part of the treatment for the COVID-19, and is a part, definitely eosinophilic viruses. It is eosinophilic lung, not a virus. Eosinophilic lungs. It is a treatment in a tropical disease, a big problem, including me. I went through that. So hetrazone saved millions of people. So nobody knows he invented the hetrazone. He discovered hetrazone. The second invention, that is invention. Now they're trying to use that hetrazone tablets for Zika virus and other areas, river blindness. They may be using that to treat that. So he is the discoverer for the hetrazone tablet. Then the mother of all his inventions came. In 1940s, the biggest disease for the children in the cancer is the blood cancer. You cannot do the radiation therapy, or you cannot do surgery because blood is disseminated in the entire body. So you need a targeted drug. They don't have the targeted drug. So he discovered a chemotherapy that called methotrexate. Methotrexate is the first drug is a antifolic, analog to the folic acid. Sidney Farber was his colleague. He's not a colleague, actually. He took his Sidney Farber is a big talker, and he is a doctor and he's a pathologist. He took it from a Dr. Subbarao, this doctor, the invention, and ran away and then published his paper. Not published. He was using and doing the methotrexate drug. It was approved, actually. Methotrexate, that's the only targeted drug for chemotherapy drug in the 1940s for the blood cancer, leukemia, and other diseases. Then the fourth invention, that is the third invention. Fourth invention is he invented the first broad spectrum antibiotic. So aureomycin, he invented the aureomycin. So what he did was very interesting. Odd couple, all triple here, I can tell you. Benjamin Dugar is a slave master, is a plantation owner from Alabama. and he was in New Jersey. Dr. Subbarao is in New York. The Lederle Labs located in Pearl River, New York. So he was. So nobody wants to hire him because not he was discriminated. the the plantation owner was discriminated because he was a southerner. So he was so Dr. Subbarao was the director of the lab for the Lederle Labs. He hired the Dr. Benjamin Dugas, and then they came up with the medicine. It's a aureomycin. It's a first broad spectrum antibiotic. It is a gold color. Is a Greek name, I think. It is a aureomycin. Is a Greek terminology. It's a gold color, it says. But it is the first they came up. They know that it is working, but they need a clinical trials. Who is going to give a guy from a southern United States, a guy from a plantation master, and then guy from India, southern India, who is going to give a clinical trials? Nobody wants to engage the clinical trials for them. So Lederle Labs is particularly small lab. So what they did was they went to another famous African American surgeon. In fact, is a Dr. Louis Wright. He's from Georgia. Actually, he's from LaGrange. I've been there a few times. LaGrange, Georgia. I placed doctors around there, around that area. He's from LaGrange. He's a slave. He's a slave son of a slaves. So these three together, these two guys went together to the Harlem Hospital where Dr. Louis Wright was in charge. They asked him, can they do the clinical trials in the Harlem Hospital? They allowed. Dr. Louis Wright gave them an opportunity to do. It was a phenomenal successful. The results for clinical trials went there without a glitch. It is 97% as effective, and it was one of the biggest news. So the automation saved millions of people, as you know. As I don't need to say that, it's still saving a lot of people, and that is a three-odd couple. They saved the lives that nobody wants to talk with those big labs. At that time, they got together, solved this problem. They don't have the patents. They didn't do anything. They really sacrificed their lives to do that. They are really so. Then Harlem Hospital clinical trials they did. I told you that was a humongous success. So automycin became a then in that's December 1940, the December of that year, they approved the automycin as FDA approved it. But before that approval, Dr. Ella Prakada died in his sleep in Pearl River, New York. He died in his sleep quietly at the age of 53, very young age. He died. His contributions were enormous. He did not get a single Nobel Prize. They mentioned him in the Nobel Committee, but did not get any Nobel Prizes. He deserves 4 Nobel Prizes. Every invention is what American Medical Association, there in the manifesto, they talk about him actually. So he was one of the history was not. But when he died, the New York Herald Tribune, one of the most eminent medical minds of the century, it said that is written on article on him. And the Jewish advocate said that because he lived longer. That is his contribution. He was not known even in my hometown. I am from same religion, same place, same thing that I came from. I did not know so what I'm trying to say is, on personal note, Dr. Subbarao reminds me of my late father, teacher, doctor extraordinaire. Both have the same name and both helped people. My father had nothing. He provided care for people who had nothing in small southern village in India. People come and go, but the nobility of these people who serve silently create and shape the better tomorrow for all of us. Thank you for listening. Let me bring um, let me bring Irene back. What do you think, Irene? Did you hear about him? Have you heard about him before? Nobody knows him.
No, I never heard about him. Thank you for the presentation.
Yeah, thank you. So it is, this why we need to have health equity officers and all the health equity. You need to watch out for these kind of people to give opportunity. We became a demi. We are worshiping. I lived in Silicon Valley. We are worshiping demigods. Now we need to really. These are the people that we need to really contribute, people like you who need really contribute so much to the world. We need to pay attention to that. We need to recognize them. You are truly on the forefront of that process. Tell me, what do you do in the Meritive Health, Irene? What exactly you do?
Well,
What they do, what the Meritive Health does, what the Meritive company does, and what do you do in that? That is a better question.
oh, the question is, what does the medical field?
What is your company? What they do, and what do you
Oh,
do in that
okay, okay.
company?
You mean, so yeah, Merative is
Meritive, yeah.
now been rebranded, right? So we were originally IBM Watson Health, and IBM Watson Health has was purchased by a private equity investor and has rebranded it to Merative. So it's basically the same services that working with clients basically to address all these, present healthcare challenges through data insights, through technologies, whatever we can leverage to really help our partners, our clients, improve healthcare and solve their problems. We have a range of clients that we work with. So in the hospital, we have 6 solutions, right? But we work across large employers, the healthcare ecosystem, so large employers, life science companies, um, health plans, leveraging some of the tools and technologies that we we have.
What do you do in that? What is your job there?
So in my role as Chief Health Equity Officer, uh, it's basically helping to support enhancing the technologies to make sure that we are, I provide leadership not just for health equity, but for health, right? Making sure that we are advancing our culture of health equity, making sure that we are promoting ethical AI, diversity and inclusion across the company. Um, so thinking about how we can promote our technologies to make sure it's for social good. The goal is to identify opportunities to use our technologies to promote improved healthcare, to promote equitable healthcare, leveraging the data assets that we have.
You're a faculty member in the George Washington University in Milken Institute of Public Health. Tell me, what is the role of there? What do you do there?
Oh, well, this is mostly, usually across, in the past years, I have been a guest um, lecturer, just, helping to provide seminars on healthcare and technology and health equity. And just most recently, I joined to really help support the current health equity, health workforce, health policy. So I'm still trying to figure out, um, a make sure that I work on health policy and management around AI and machine learning tools and what will be needed. So we're still trying to devise a curriculum or um,
No, you're
project.
doing you're truly a treasure to American system, American healthcare system, Irene. Truly an honor to talk with you. And if you can stay there after this broadcast, I will talk with you a couple of minutes. But it's truly an honor. You're a really blessing to the American healthcare system. You're people like
Thank
you.
you
We need
so
it
much.
more and more. Thank you so much. I'm gonna tomorrow. We're having a. I'm interviewing a physician astronaut, a doctor, and the aquanaut. She goes into the bottom and the top, both, and the into the space and into the marines. So I'm going to talk with her. Let me thank you so much. It's truly an honor to talk with you, Irene.
Thank you. Thank you for inviting me for the opportunity.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.